So he started coding when he was about 11 on the Apple Developer Program, and he has an undergraduate degree in neuroscience from Binghamton University. And his current focus today, and we mentioned he's a second-year medical student, is how AI can be effectively integrated in healthcare delivery systems. And a number of us mentioned yesterday the story on NPR about AI. And so, John, we'll let you go for it here. I'm going to have to jump right at 8 o'clock. I have another meeting at 9, but I'd like to just propose that our next BSCME meeting be on November the 30th. That's the week after Thanksgiving. So we'll get some good stuff going on there. We'll set it on the 30th. So any other things for the good of the order? All right, John, you have a lovely place where you have, is that a real background where you're at there? Because it's stunning.
Yes. Yeah, this is my home.
It's stunning. It's stunning. So,
thank you.
All right. So, John, over to you. You have the floor or the screen or whatever. So, over to you, John.
Okay. Thank you. Well, Dr. Farstein, I really appreciate that warm welcome. I'm very excited to be here today. As I mentioned, or as was mentioned, we're going to be talking about the role of AI and how that's impacted both my medical education and some clinical integration that we might be able to see moving forward. And we really have 3 goals for today. I'd like to give you guys a background on the current state of artificial intelligence and how that differs from prior technology. I'd like to discuss how AI can be incorporated into medical education and how I specifically have been integrating this technology into my education. And then I'd also like to talk a little bit about potential areas in healthcare that have a lot of potential and are ripe for innovation using this technology. And before we really talk about large language models and deep learning, I think that it's important to understand the historical context. And there has been a desire to integrate clinical decision-making for decades now. And we really have 2 areas that stand out to me as being the first real push to have clinical decision-making be assisted by a computer. And the first was the Cornell Medical Index. So this was 198 yes/no questions that were attempting to generate a diagnosis. And this was starting in 1949. The Cornell Medical Index actually is really a foundation for our current review of systems. If you go and look up what this index looked like, it looks very similar to a comprehensive review of systems. It was meant to be something that patients could do in 15 to 30 minutes. And the idea was that you were going to be able to gather a database of information provided by the patient before you actually went and saw them. And that having this database, we are going to be able to make decisions and have better insight into the patient's condition. Now, this was taken a little bit further from Leeds University with the AA Help program. And this was actually the first real computer-assisted diagnosis tool. And they were looking at diagnosing the acute abdomen in a surgical setting. And this was published in the British Medical Journal in 1972. They were using a punch card computer system. And it was actually quite impressive. I believe that their rate was around 92% in terms of accuracy. So even back in 1972, we had this idea that we have computers, we have physicians, and we can work with them together. Now, these are actually the studies that were posted, and I think there's just a couple quotes from them that really stand out as being impactful. The Cornell Medical Index, they said a number of studies in the United States and Britain have demonstrated its value both as an aid in diagnosis and as a screening procedure. The attractiveness of the Cornell Medical Index for epidemiological use lies not only in its ease of administration, but it's also its subsidiary role in clinical care. And this was 1949. So I think it's so interesting that we see stuff in the news about, oh, how can AI and how can computers help doctors? And this is a conversation that's been going on for the last 70 years. And then if we look at some of that clinical diagnosis in terms of the Leeds University, they have a Bayesian analysis that they tried running, and it would take about 15 to 20 minutes. And I love this last little quote. The system was far from perfect, but using identical information, it made significantly fewer errors than the clinical team. And I think that is just so crazy because you look at that, that was 1972. So this idea of technology and computers being integrated into clinical practice is not something new. So I would like to just take that now to describe what those systems were and how the new ones are different. And again, for emphasis, 1949, 1972. This is not a new concept. So what happened? If we had this significant breakthrough in the 1970s and 1950s, why is it that today we're still having the same conversation? And that really underscores the architecture of what those systems were doing. They were algorithms, the same way that we have a lot of algorithms. This is actually the current algorithm for an acute abdomen from UpToDate. And we're really leveraging pertinent positives and pertinent negatives when we look at using algorithms in healthcare. And that's great. We have a lot of evidence-based research studies that we can use to inform those decisions, but people don't always fit in the algorithm. Sometimes the pertinent positive might be subjective, or the pertinent negative might be somewhere on a spectrum. And so you have an inherent error there in that you cannot capture the full brevity and full experience of the patient's condition using an algorithm. And that ultimately makes it challenging. So now we have neural networks. So I'd like to explain to you what a neural network is, how that differs from those algorithms, and how we can use this new technology, neural networks, to improve healthcare. And so just for some context, neural networks are a relatively new technology in their mainstream adoption, but a lot of this pioneering work also went on in the 1970s. It's just that now we have the computing power and really the push and the market capitalization to use this technology. So what a neural network is, if you understand how the brain works, and in terms of how neurons work, you already understand neural networks because the core foundation of them is very similar. And I like to say computer science takes a cue from Mother Nature. I know when I was in my undergrad, there was a saying, and it's neurons that fire together, wire together. And you see that with neural networks in that the network actually has different nodes that are interacting with each other, and you have patterns of those nodes that will generate an output. And it's sometimes the pattern that is most important, similar to the human brain. So this is kind of a very brief introduction to what a neural network actually looks like if you're going to try to visualize it. I'll read the text and we can kind of just describe what it means. Neural networks use layers of nodes akin to neurons to process and transform data. Each node is going to receive an input, process it using a mathematical function, and send the output to the next layer. And this is really important in terms of going on to the next layer, because what transformation happens in one spot is really going to be impactful for what the next node or neuron is activated. And that's what's generating the pattern. As data moves through these layers, the network fine-tunes internal parameters called weights to optimize its predictions or classifications. This fine-tuning is guided by iterative feedback, allowing the network to learn from errors and improve over time, ultimately enabling it to recognize patterns and make informed decisions about the input data. And so ultimately what we have here is we have an input and we have an output. And using this neural network, we are able to have a computer figure out the relationship between that input and that output. And sometimes these neural networks can have billions and billions and billions of parameters. Here, we only really have 2 nodes that are working. But when we talk about ChatGPT or the Meta LLMA model or most of the AI stuff that we see, it's not this simple 2-layer structure. There's many, many, many nodes here. And that's what makes these systems so powerful, is you have the ability to have an input and figure out a relationship with the output. So how do they actually learn? Well, that's a little confusing, and I will say that I'm always looking to improve my knowledge of this. But from what I understand, the networks do not necessarily learn the same way that you and I learn. Now, from a core and foundational perspective, absolutely, right? They're having an input, you're having a series of neurons or neural network nodes that are firing in a specific order and their specific weights. And so that's very similar to the human brain. But what they're actually interpreting may not be the same as you and I. And for example, this is just a demonstration here of this picture of a lion. The neural network might not be looking at the color or the gradient or the fine features. It might just be looking at a very rough outline of edges and contours, the same way that the human brain and the occipital lobe also will derive information from our visual environment. And it might find a connection to figure out, hey, this is a lion that is completely different from how a human does, but it still gets to the same input. And this really is foundational in the fact that you have the input, you have the output, and the neural network is going to figure out the relationship between the two. So the key to all of this is really in our data sets. And that makes intuitive sense if we consider if we're going to have an input and an output and we're going to train on those two things, what we're putting into the system and what we consider the ground truth for the output is absolutely critical, because you're having what's called backpropagation. And that just is a fancy way to say, when we start with our network, all of those nodes I was talking about, they're all random. We just start with a randomized network. It is horrible. It doesn't work at all because it's using a random data set. And then when we actually do the training, we'll have the system try to find those connections, and we're going to give it feedback. So we have the input. It thinks, hey, I think this is the output. Maybe it's the picture of that lion. So you give it the input picture and it says, I think it's a dog. And you say, nope, go back, right? This is a lion. And so it's this process of backpropagation and training the neural network that is what really gives them their foundational value. And so to do this, you need to have good inputs and you need to have good outputs, and you need to be confident in the data that you're putting into that. And this is an important concept because it really will drive some of the growth points that we have later when we talk about neural networks. So the inputs and the outputs, like everything, even in healthcare, are so critical here. And these are just some of the companies that are involved in this space. Nuance, Copilot, which is a part of the Microsoft thing, Google Bard, OpenAI, everyone has heard of. I believe that's the ChatGPT company. Amorphic, they have a model called Cloud. Poe has a separate model. And Meta actually has an open source model, which is pretty cool, that you can run for research purposes, because these are very, very expensive in terms of both compute power and in terms of the machines needed to run these models and do that training that we are talking about. They're very challenging to run. And so it's great when you have an open source option where those weights are already released for public use. And now I'd like to talk a little bit about how we can use this in medical education. And so this is some examples of what I have done in terms of using this technology. So as a second-year medical student, a great way to learn is to do practice problems, and particularly to get them wrong. And we have absolutely fabulous instructors at the Jacobs School of Medicine, and we're given practice problems, but sometimes there's not enough of them, especially if there's a specific concept that you want to work on. So this is an example of some of the inputs that I've had with the system, where I share that I'm a second-year medical student. I share the area that I'm currently focusing on, and I will give the system my learning objectives. And then it will write me questions. And one of the really valuable parts of these specific questions is, number one, they can target the board content and the in-house content by giving it the specific learning objectives for my lecture. I can even give it the lecture slides if I want to really have it honed down its accuracy. And the second part is when I'm actually doing these practice questions, since this AI system is not perfect, and we're going to talk about a little bit why later on, there's really two layers of education going on. There's actually answering the question, and then there's fact checking the AI to make sure that the explanation it's giving me is correct. And so you're getting a double effect in terms of learning and reinforcement of learning with these practice questions. And if you guys have ever tried writing practice questions for a research study for a class you've taught, it is challenging. This is an incredibly powerful tool, especially when you're trying to figure out incorrect answer choices, but that are reasonably close. It's not something that I could do on my own, and it's been incredibly valuable for me. The next is giving it practice questions from textbooks. So I still use textbooks, even though a lot of our courses are online, and I still find them really valuable. But sometimes I'll get a question wrong from the textbook, and I don't really understand where the disconnect was. We're lucky if there's maybe a sentence or two describing what the correct answer choice is. And that can sometimes not quite fill that knowledge gap of why I got a question wrong. So what I'll do is I'll take those questions from the textbook. I will have it try to answer it first to make sure that it gets it right, because I don't want to be taught from the system if it gets it wrong. And then I will have it walk me through, like a tutor, how it solved the problem. in conjunction with writing 3 or 4 problems like that to test my knowledge and underscore that I truly understand the topic now. And I just want to think for a second about how valuable this technology was. If you think back to your time when you were in either medical school or graduate school and you had to study for an exam, the ability to take something that you know you're struggling with, have it walk you through like a tutor, and then test yourself continuously on that material is incredibly valuable. And it's something that I really think that we're going to see expand over the next 5 years in terms of medical education and education as a whole. The next area is, this is actually a voice interaction, and I want to see if I can get this to play for us. So you can have a voice to text interaction with the AI, and this is very similar to having a conversation with a mentor. And it can give you a clinical prompt, and you can try to answer it. And I have a quick recording here of one of those.
Here's a case for you. Patient, Mrs. Brown, a 65-year-old female. Presenting complaint, 5-day history of fever, productive cough with yellowish sputum, and increasing shortness of breath. History, Mrs. Brown states that she has felt generally unwell for the past week. The cough started as a dry one, but has become productive over the last 2 days. She has also noticed a sharp pain on the right side of her chest, especially when she takes a deep breath or coughs. She denies any recent travel, animal exposures, or any sick contacts. Past medical history, hypertension, well controlled with medication. No history of diabetes, heart disease, or other chronic illnesses. She has never smoked. Last pneumonia vaccine was 5 years ago, and her last flu shot was this past year. Physical examination, vitals, temperature, 38.5 pulse, 90 ppm, respiratory rate, 20 breaths a minute, blood pressure, 130/85 millimeter Hergov, oxygen saturation, 92% on room air. Lungs, decreased breath sounds and coarse crackles over the right lower lobe. No wheezing, cardiovascular, regular rate and rhythm. No murmurs. Other systems, unremarkable. Laboratory tests, blood, elevated white blood cell count with a left shift. Consolidation in the right lower lobe. Now, considering the history, examination findings, and the chest x-ray, what is your diagnosis and suggested treatment?
This sounds to me like a lobar pneumonia, possibly from something like strep pneumoniae. I also noticed the pleuritic chest pain. Could you please talk about that more and its significance in her clinical presentation? If it is strep pneumonia, we might want to consider a treatment regimen consisting of ceftriaxone and azithromycin.
Absolutely. You're on the right track. The pleuritic chest pain you noticed is significant. It indicates inflammation of the pleura, the membrane surrounding the lungs. When the pneumonia infection involves the pleura, it can lead.
We can move on from that. But I think that really underscores an important point, and I thank you for sitting through that, because as a student, it is so valuable to be able to have a conversation. And if you take it off, and I think this really expands past just being a student, to interact with technology in a way that you can have a natural voice conversation with a relatively normal cadence is absolutely critical, because it allows you to communicate in the way that humans are most used to. We grow up talking and engaging via tech or via speech, not on keyboards. And I really think this is a critical way to incorporate AI into the medical education with that natural communication. Now, this isn't to say that it's been perfect in terms of helping me with my medical education. And this is just a quick example from last week. Right now we're in our pulmonary module, and I'm working on improving my EKG diagnosis and systematic approach to them. And this is a characteristic S1Q3T3 for a pulmonary emboli. And I asked ChatGPT to help me understand and walk through a systematic approach to reading this. And it says normal sinus rhythm all day, every day. And so this really drives to the fact that the system is not perfect, that it can make mistakes, and that as the person using it, we really have to be vigilant about what it's saying and whether or not that's correct. But that really drives home a specific point with how these models were trained. They started with text. And specifically for a lot of the large language models, they ingested hordes and hordes of data from the internet, Twitter, textbooks, websites. And so the image stuff is really the next step in that, but it's not quite as fleshed out as the text area. And so I think an interesting kind of correlation to that is if I give it that EKG, it says it's normal sinus rhythm when it's not. But if I give it a history, the same way that you might get from a patient, it's able to get it almost immediately. And I think one of the statistics that was shared with me when I first started medical school in our clinical practice medicine course was that you can get almost 90% of all of your diagnosis from just a history alone. And this system really does demonstrate that. So that's how I've been using this technology in my medical education. Now I'd like to talk about some clinical tools and how it could be used by physicians. And just like creative problem solving is a incredibly valuable tool that we can use to approach situations, I think that AI can be used when you're independent or you don't necessarily have your team with you to help creatively think about specific problems. And here I gave it the scenario of a physician who's working in the hospital to improve the outcomes of patients who have respiratory infections after surgery. And I asked it, just give me some ideas, stuff that we might want to consider doing. And it had 3 that it outputted. One, it was using virtual reality to help teach patients how to do like a pulmonary reconditioning. And that didn't seem to really resonate with what I thought would be successful. But there was 2 ideas here that I really could see being implemented in a hospital setting. And I think about this as a tool to rapidly prototype different ideas that we might want to be able to use to implement into clinical practice. And the value of this is the fact that you can do this alone with the AI system. You don't need to have your whole team with you, that you can really prune out the best ideas, and then you can bring it to the team setting and talk about how you could incorporate this into your actual practice. And really, the ability to rapidly brainstorm using this technology is something that we have not had with anything else. You can also use this technology to translate topics that might seem confusing. And I think a really great example of this is if you're working with a population that maybe has a lower health literacy, it can be very challenging to explain some of these medical topics and have that in a language that the patient can really understand. And so I had an example here of an individual that comes in with atrial flutter, and we're figuring out whether or not we'd want to use amiodarone. And this individual had a interstitial lung disease that really made them a poor candidate for that drug. And how do we explain that in a way that makes sense to someone that maybe didn't graduate high school and has worked in a car manufacturing plant? And so if you look to the right of the screen, I said, take this SOAP note and for this patient and give me a single paragraph of what this patient's condition is and have it in language that they understand. And so in this case, this hypothetical patient had worked in an engine manufacturing plant. And so here we have an example of the patient's condition with terminology that they would hopefully be familiar with. In this case, an engine misfiring, the medications being akin to an oil that helps keep their system running. And I really think there's a significant amount of value in that, because as healthcare providers, there is so much time that you are working, and to sit down and really think for each person, okay, how can I translate this to something that this specific patient would really understand, is maybe not feasible for every single patient. But using this technology, just like with the problem solving earlier, you can rapidly prototype different ideas and translate it. And even if you don't copy it word for word, it gives you an idea that you might have not otherwise had, or had the time to really sit down and think about. If you think about your clinical practice, how often do you think that you'd be able to sit down and really translate a patient's condition to their specific medical knowledge in terms of kind of where their education level is, and also what's significant for them in their life? So those are some clinical applications that you could be able to use this technology for. Let's talk about kind of the state of the art and some growing pains and some areas where we're working on improving AI, but it's not quite perfect yet. And we already saw this a little bit with the EKG interpretation and some times where it gets it wrong. And I think a really important part of this is your model is only as good as your data set. And if you think back to the slide we had earlier with your inputs and your outputs and that backpropagation of the network, you really need to have a confirmed and confident output that you're able to say to the system, yes, you are correct, or no, you are not correct. And ultimately, medicine is an art along with the science, and there isn't always a correct answer. And I really love this study. This was shown to me from a book called How Doctors Think about radiologists, and they were looking at the same chest x-rays and seeing, is it normal? And we saw really a significant inter-observer variability. And so this was in 2006, but they had about 100 radiologists that wanted to be in this program to see how they compared to their peers. And there was a disagreement within themselves of, is this film normal about 20% of the time? And then if you took that same film and you a week later showed it to them, there was about 5 to 10% would change their answer. If they said, oh, it's normal. Now they said, oh, I don't think so. It's abnormal. And that really drives home the point that we don't always have the perfect, clean-cut input, output, it's confirmed. And that's a challenge. That's a challenge when we think about building these networks, and it's something that we need to be mindful of. And again, this is really just hitting that point back about we need to have confidence in our output to be able to train these systems well. There's also what's called spectrum bias. And this we're really familiar with if we look at positive predictive value in specific populations. We talked about this a lot with COVID in terms of the COVID test. Well, can I be confident in the rapid test? Well, it depends on the population you're in. If COVID is incredibly rampant in your population and you have a positive COVID test and you feel unwell, yeah, you can have high confidence in that positive predictive value. If the incidence goes down significantly, then that changes. And if you think about kind of that concept to training these models, we are training on a national, on a really international, global data set. And if you want to then apply this technology to, let's say, here in Buffalo, you're going to have differences because the incidence of different diseases is going to be different here. And again, it's not something that is a make or break. It's something that we should be aware of, though, when we're using these systems, that they might not have the same intuition that you do. And I really think a way to consider this and to think about it would be a large language model for diagnostics. And let's say you have 2 of them and you're the person that's working in the hospital and you're helping determine whether or not we're going to use this AI model and which one we're going to pick. And you have majority accuracy with the first model of 98% for the overall population, but with a minority patient population, it's only 80%. Or you have a majority accuracy of 95% and a minority accuracy of also 95%. Which one do you pick? And I don't know if there's truly a right answer to this. It's something, though, that we should be mindful of, especially as we talk about rolling out these technologies. We have to consider, what was the data set they were trained on? What were those inputs? Because those are going to drive the outputs. Now, we also have some really exciting real-world applications that we're starting to see roll out. And so this was a paper actually from 3 days ago that was published by Microsoft Health Features and Harvard. And they were looking, again, in radiology with using ChatGPT-4. And this is really new in the sense that there's always been AI. And I think that there's been a significant conversation in radiology specifically about AI and its impact. But this is the first time we're really using a large language model instead of something like a optical character recognition. And so they found GPT-4 either outperforms or is on par with the current SOTA radiology models. And then if you prompt the system, it obtains really substantial gains, about 10% in absolute improvement and its classification of the natural language interface. And a really interesting part is the errors in complex content that required nuanced domain knowledge. And so what that means is the system is struggling with the really complex cases the same way that a human does. And this makes a lot of sense intuitively if we think back to it's all about the inputs and the outputs. If we don't have a really strong ground truth for that output because it's complex and there's some subjectivity in there, of course the system is going to struggle. And I really think that is so interesting because it's just like humans. And it gets to this point that the ground truth is sometimes a little ambiguous, and that as we start to use these technologies, it's just something we have to keep in mind, the same way that we have limitations for all of our tools. There's also some interesting AI human-like behavior that you can see. And so this was an article from the Google DeepMind team that was just published last month. And they found that you could improve these AI systems' knowledge and their accuracy by prompting it with the prompt, take a deep breath and work on this problem step by step. And it improved the accuracy 80.2%. Now that's crazy. If you really think about it, this is a computer system. And if you prompt it the same way that you might be prompted by a friend, hey, take a step back, take a deep breath, let's work through this step by step. Just like a human, the computer model is having significant gains in its accuracy. And it really drives home the point that these systems are more similar to human in terms of their fundamental architecture than any of those algorithms that we were talking about from the 1970s and 80s. And I think the real big takeaway that I'd like you to take from this presentation is that AI is a tool. It has significant ability to impact really meaningful change. And AI is a tool the same way that creative problem solving is a tool, the same way that having really great colleagues around that you can collaborate with is a tool, the same way that we have clinical decision-making flowcharts, the same way that those are a tool. And this is a really powerful tool. And I think that a really exciting part is now you get to take this tool and use it. And I know there was a lot of excitement 30, 40 years ago about the EMR being rolled out as a tool. And in fact, this was the most recent JAMA article about whether or not electronic health records are going to have a similar path with AI in terms of it was a really promising technology. There was a lot of excitement. And obviously, we saw the electronic health record did not turn out to be this beacon that was going to save physicians. It really had a complete opposite effect of that. And what I would really encourage all of you to do is to use this technology, even if it's not in a clinical sense, even if you just download ChatGPT or Poe or Cloud and you just use one of these models and talk to it. It doesn't need to be about work. Right now, I'm currently training for a half Ironman, and I have the ChatGPT make my training plan for me. I mean, it doesn't need to be something that is clinical. It doesn't need to be something that is work. I mean, you can ask it, hey, give me some recipes, or take a photo of your pantry and say, what can I make for dinner tonight? And, you know, give me a great recommendation. It doesn't need to be necessarily work related, but get involved with this technology so you can have some experience with it. One of my great mentors, Amina Abadi from the Erie County Medical Society, shares a quote, and that's, if you're not at the table, you're on the menu in terms of negotiations. And I really look at what happened with electronic medical record as physicians not being at the table. And we have such incredible potential with AI that let's be at the table, right? We're not going to be on the menu. Let's use this technology to improve our lives, to improve patient care, and to make work a little more enjoyable. Here are some further education sources. I'll make sure that these slides get sent out along with some of the papers that I referenced. And with that, I'd like to turn it over to any questions that you might have.
John, this was absolutely magnificent. Fantastic. Great job. So just once I'm just gonna kind of advocate from solving the real problem. I love what ChatGPT said. It's like when you take some time and step back to try and go through the process step by step, you get better answers. And so that's sort of my bully pulpit I've been on recently with the new book. And so I'm going to use that quote in one of my new presentations. So thank you for that. Just fantastic stuff. Let's open it up. Let's have some conversations around this. John, thank you so much for taking the time to put this together. It's fascinating. And so what do we got?
Can I start?
It appears you have, Dr. Gatewood.
Well, that was absolutely fantastic, and I know we share the same passion with AI. Just a couple of quick comments. One, this was put online last night. It's not. It'll be in paper probably. I'll get it in the mail this week. But the headline here is AI will dash and should dash change medical education, says Harvard's Dean of Medical Education. So what John is promoting here is not just his dream or his view. This is going to be a transformative technology. It's just going to change everything in medicine, including medical education. This is one from last week from JAMA, and that also is all about AI in medical education. This is a fantastic paper, and this is AI and medical education from the New England Journal in, let's see, August of this year.
And Dr. Gatewood, to your point,
In July, this is AI in healthcare from the New England Journal of Medicine. This is here to stay. The genie is out of the bottle. And I agree totally with John when he says we as physicians need to be up front, leading the charge. I was one of those slackers in the 80s when we didn't get involved in the development of EMRs. I hopefully learned from my mistakes, and I hope other physicians will, but I'm really hoping that particularly young physicians like John can really lead the way. And John said something else to me recently, which is very, very important. And you brought it up, but you didn't quite say it as you told me. But Roger, this is what John said. It basically, and John, correct me if I'm wrong, but this is a perfect opportunity to marry AI with creative problem solving.
Absolutely.
So what I would say is, you might say something, and you used a little bit of an example, but what might be all the ways AI can, and then put in your question, improve EMR charting, improve patient-doctor experience, improve diagnosis. I can go on and on. There isn't one, I can't think of one aspect in medicine and in healthcare that this cannot apply to. And so I know I'm maybe a little bit of a reckless optimist, but and hope and like John said, there are some hiccups with it. It's just like computers, garbage in, garbage out. If you give AI garbage, one example that was recently published was that we used to calculate, and maybe Dan, you can correct me if I'm wrong on this, but we used to correct the lung volumes of Black males differently than white males. That was changed just a couple of years ago, but it's still in that database. So if you go in and use AI to do that, you're going to get the wrong answer. The same thing in how you calculate the GFR in Blacks versus whites. It's no longer done that way, but it's still in the system. So we have to figure out how to keep AI up to date as well and get that old information out. I always tell my students, and I hope I don't bore you that I've already mentioned this before, but 50 years ago, medical knowledge doubled every 50 years. In 1980, when I started practice, medical education doubled every 8 years. In 2020, medical knowledge, I should say, medical knowledge doubled every 73 days. So there's new information, and a lot of the things that I learned in medical school are totally wrong now. An example is, if you gave a patient with heart failure a beta blocker, that was no. Now it's a class 1A recommendation. Same thing with digoxin. We used to always start with digoxin. Now digoxin is like a last sort of drug in your armamentarium because of the risk of drug toxicity. So yeah. Anyway, I could go on and on. We have been talking, you mentioned DAX Copilot, which is a new name. And maybe, let me just say, DAX Copilot is a program that Nuance has. It's a Microsoft program that they're starting to embed in EMRs. The one that they just embedded in was Epic, which is, now I see this as solving that problem that you brought up, John, about, what's the incidence of COVID in your area? If you've got all that data in the EMR in your particular community, now AI can go in and see, is there an outbreak of COVID in your community? So when a patient comes in with symptoms that suggest AI and there's an outbreak in your community, the antennas go up and it helps to, make that diagnosis. So yeah, I could go on and on. I'll stop here.
Robert, I appreciate.
I'm just so excited about this technology.
I appreciate your reckless optimism any day. Thank you for that. Yeah, Dan, jump up. Yeah, go ahead. No, good. Yeah,
Sorry, Robert. So really,
you mentioned update. Update is now going to have AI embedded in it. So yeah, it's everywhere, guys. It's the genie is out of the bottle, and it's our responsibility to really make sure that we manage it well and we apply it the way it should be applied.
Yeah. So John, really fascinating, well-polished presentation. I think in order for some of us to gain trust in ChatGPT and AI, I think one of the first things is not to use it to make the diagnosis, but to kind of narrow that differential diagnosis, or to narrow the drugs that we use and to kind of through it. Have you had a chance to share it with anybody in medical education at UB?
Yeah,
this similar presentation, and how was that received, and who's going to be in your choir?
So this presentation was made for our meeting today, so the presentation has not been shared. Some of those practice questions, though, I can assure you my colleagues have found very helpful, particularly when we all run out of practice. So the actual output I've been able to share, and they've been very grateful for that in terms of this specific presentation and incorporating AI in the medical school. I know that Dr. Gatewood is working on that. It's something I would love to see, but it has not yet been shared with the school at large.
Okay, so we got to get you on the table with Dr. Leslie and Dr. Melling and Dr. Mecca, and that we'll work on that when I return.
And I will be on your choir as well.
Yeah, love it. Yeah. Other comments? Yeah, John, this presentation, as far as presentation wise, is just so succinct, so well put together. Just really, really well done. Really well done. And I think it's a great flagship that you could use to get out there to really introduce this, because it makes sense, and it's really at a level that's very approachable. So other comments?
I would just like to say, so I was asked to put together an AI policy for the school, and I worked with an expert from another school, and we put something together. I'd love for you to meet with you and go over the policy and see, because I know it's constantly changing. And so the policy is going to have to be revised as the technology advances. But I'd love to work with you on that policy and polish it up even more and see how we can get you in front of your classmates and other students and faculty as well, because my biggest fear is that students will see you doing this great stuff and try and do it themselves without knowing how to prime the system correctly and double check the facts or the generated facts, and then rely on that to prep for step one or whatever and miserably fail.
And I want to raise up a specific point there, in that this system, one of the reasons I spent so much time talking about some of the areas of growth and areas that it's not perfect is the system is still learning and it's still growing. And I think from an educational standpoint, that's a strength, because as a student, it forces me to look at the content twice. I have to do it once for the question and once again to reference my notes to see, okay, it gave me an output. Is this accurate? Does this make sense? Is this a true ground truth? And I think that is a point that is critical to be shared with other students as they go to use this, is that's half the value of something like this system.
Absolutely. And the important information there is, to double check the output, whereas others might not.
Great point, Tanya. Great point. Yeah. Robert.
We still have time, or?
Yeah, sure we have time. Yeah, we're good.
Okay.
We're good.
So Dan, on the diagnosis part, yeah, I know there's some hesitancy on that, but I look at it as AI is sort of, and John's kind of alluded to this, it's a second pair of eyes. It's like having a colleague next to you. They just are raising some possibilities. So it's a matter of you're almost a team with the AI, and that's the way John's using it in learning. It's the same way we can learn. We can use it in making the diagnosis. I probably have shown this graph before, but this is out of Thomas Friedman's book. Thank you for being late. If you know Thomas Friedman, he's a great journalist and book writer. But this is a book about it's about the 10 years from 2007 to 2017, and 2007 marked really when technology really took off with Steve Jobs and the iPhone. So you probably can't see this, but anyway, there's AI or technology is going up like this, and our ability to adapt is like this. Mm-hmm. We're generally slow at adapt, and particularly physicians, because we're risk averse, and that's a good thing. You don't want to be, reckless like me. You want to be, you want to be very careful. So, physicians tend to be a little slow on adapting things. Sometimes even guidelines, we have trouble keeping up. Guidelines are published, and then they're just, it's 5 or 6 years later before they're really being used universally. So we have to recognize that and hopefully help overcome that. And that's maybe where, again, creative problem solving may come in. How do we get physicians to what are all the ways we can get physicians to adopt things a little earlier when the evidence is there in front of us? So yeah.
Well, I'm beginning to see a topic that we might address, perhaps not in the next session, but in the following one. It's like, John, I think, Robert, you and I need to have a little sit down and come up with a little session on how to put creative problem solving along with Chat GPT AI, because it's just, and it's just such a great adjunct to it, just a great use to it. So we'll continue that. So other comments or questions? Thank you all for being here this morning. John, thank you for such a great conversation. So
Mike,
John,
or yeah, anybody, any other comments? Because I've been doing too much talking, and I apologize. I can't.
I love your enthusiasm, Robert. I want to grow up to be like you, Robert.
I'd love to hear more comments about this, really. This
David,
is,
David, over to you. David, you wanted to get on something? David? Yeah.
Yeah, hello again, John. Welcome back to the creative problem solving world. Like Rod, I'm also a doctor, but not
Right.
the kind who helps people like the rest of the doctors who are in here. And I've been studying AI as for use in general education and creative problem solving. And of course, there's a lot of discussion about the potential of AI to replace, right? Not augment, but to replace in the case of teachers. So my question for you in terms of medical education is the medical profession going to need to step up its game in terms of educating not just each other, but the public? Because if a doctor can prompt AI to say, give it the parameters of a diagnosis, so can anybody else who's out there. And I just wonder if there's going to be a potential challenge of do-it-yourself medical practice where people go in and they feed the diagnosis or they feed their symptoms or whatever they're doing and they get a response. What do you think about that potential?
So I think there's really two critical points to that specifically. And I will add that there have been anecdotes on social media of patients that saw different physicians for many years that asked ChatGPT and it was able to figure out their diagnosis. And that's great, but those are anecdotes. And my real hesitation goes back to that ground truth. And there's two areas that really stand out to me. Number one is, what do you do with the information once you have it in terms of management? And like any tool, we have to think about what are we going to use it for? So if you get a diagnosis, that's great, but how do you treat it? And specifically, what does it mean for you in your specific clinical picture? And I think that's really where you have significant value. And the physician is they can say, okay, this is what this diagnosis is, but this is what it means for you. And I'm sure anyone who has ever gone on WebMD or, looked online because they felt sick and, saw, oh my gosh, I might have thyroid cancer or something crazy like that, can understand the critical importance of what does it mean for you, not just this is a possibility. The second part that I really think is critical here is something that Dr. Ken Snyder shared with me during our Co-Agents Change course, and that is mechanism. That is the most important thing a physician can share is the mechanism. If you just have a diagnosis, that's great, but what is driving that? How can you understand that? And using that really fundamental clinical background of this is the pathological process and this is the mechanism that drives it, that's what I really still think sets apart a physician from this AI system, is they're able to understand the process and how it relates to that specific patient. And it really goes back to almost an individual-based model. We were talking about the system being trained on international and global data. Well, when you have an interaction with a physician, it's down just to you. You're sharing your specific symptoms, your specific experience, and you're getting individualized feedback from a human physician now. With that said, I do think there is a significant value in having the public be aware of this technology, specifically even as a screening tool. I could see something like this being implemented in a hospital triage office, and you could help, for example, auxiliary staff rapidly triage patients and maybe consider stuff that they weren't originally considering.
John, I'm going to just jump in for just a second here. I need to jump, but David, I want to apologize for something, because you really are the expert in creative problem solving and AI. And I know that you are doing a session on that. So would you consider perhaps the November 30th doing a session on AI and creative problem solving with the group?
Sure. Be
Okay,
doing it
good.
with our students. I think it's November 16th, so that'll give me a chance to practice.
Okay.
I'll be nervous in front of this group.
All right. Folks, thank you so much. John, thank you very much. I have to jump. Please stay on as long as you like. And David, once again, thank you for getting to us, and welcome Sharon. Good to see you again, Tanya. John, welcome you are now an official member of the Buffalo Society for Creativity and Medical Education with all the rights, privileges thereto appertaining. Wow. See y'all. Take care. Robert, I'll see you next week for coffee.
okay. Can I just have one comment of just a follow-up to John's?
I would head off. Thanks, guys.
Yeah, okay. Yeah. To your question, Dave. Yeah, we already have seen that actually. yeah, patients would come in, because they saw Dr. Google first. And, but they still needed that doctor touch to it. And some of the articles that I referred to, they still talk about, the importance of that doctor-patient relationship and bringing it together. So yeah, I don't see, but as John said, I think this is great. It sort of democratizes health and healthcare and medicine. So I think it's actually good. There used to be a clothing store here in Buffalo, and the motto was something like our educated consumer is our best consumer, because they knew what a good suit was, so that when they came in they saw a good suit. So there was recently a quote by, and I'll read it off my phone here, by Robert Bott, the head of Bloomberg Beta. He said the effects of AI can be compared to three sets of technology. The first is the loom, which is the spinning loom, which replaced the Lundites. So this is what you're talking about. This is actually technology that replaces people. The second is the slide rule, which speeds you up while allowing you to be more accurate and make fewer mistakes. So this is, again, sort of a help. And then there's what's called the crane, which allows a human being to do things they might otherwise not be able to do, like lift a steel beam up to the 5th floor. So yes, there are three, he puts it into 3 stages. Some will be replacement, and we'll see that. We'll see that in other sectors of the economy where workers will be displaced, but they'll go to another job or whatever. So yeah, I know that's a fear amongst physicians, is AI going to replace me, but not in the foreseeable future.
Well, we'll bring this to a close. Thank you again, John, for sharing
Thank
your
you.
expertise. As everybody has said, I've been a teacher for a long, long time, and there is no technology in my lifetime that has the potential for transforming not just education, but so many different areas in such a short amount of time. I mean, ChatGPT is, at least the public version, right, is less than a year old now. It's 11 months now in October. And when you think about the way it's already, a lot of organizations and disciplines are incorporating versions of it into their into their use of computers. John, I had one other question for you that I wondered about. Sometimes I will tell my students, take the output from one AI bot and feed it into another. So take ChatGPT, feed it into Google Bard, or feed it into Perplexity or Elicit, or any of the other ones. Have you tried that, and what's been the results when you've done that?
So I can't say that I have real extensive use of that. I have used Poe, Cloud, ChatGPT 3.5, ChatGPT 4. I've used the different models. My question would be, what are you trying to get by using the multiple models? Is it an increased perspective? Is it increased data? What are you trying to do by using multiple large language models? I would say that the adage of more does not always mean that it's better. And I don't know if adding another large language model is going to necessarily improve the quality of your output. I would really emphasize that Google research study from the Google Deep Science team of, sometimes it's helpful just to ask the system, hey, step back, take a deep breath, explain it to me step by step. And that is something that I have done. I've had it go through its thought process or walk me through how it got there. And I think there's a lot of value in that, because then you start to understand, what's the real problem? What are we trying to solve here? And, from a student perspective, if I'm looking at specific questions like I had in my presentation, I think can find that to be even more helpful, because then you can find those gaps and those breakdowns in understanding.
Well, of course, one of the concerns that everybody has about at least using it in education is its the propensity to hallucinate, which is, I think, almost a comical term, right? For making errors. So that's one of the uses of taking the output from one, feeding it into another, and saying verify the accuracy of this information. Now, the second AI bot is not is not perfect either, right? But also, I will have my students compare the output of the two to develop their critical thinking skills. All right, same prompt fed into Chat GPT, same prompt fed into Google Bard, or pick yours, Claude, right? And now look at the results and analyze them, right? Curate them, and because that can help them develop their critical thinking skills.
And I would say that that's a really critical and foundational point there is you're trying to teach your students to understand and find that ground truth on their own. And recognize if you're going to look at two outputs and try to compare them, you need to have some knowledge of the subject to begin with. And like any tool, using it without any background at all can cause problems. And it can lead to an outcome that isn't really ideal. And I think that using these systems does require a certain level of expertise and knowledge about that ground truth, because although hallucinations in the models are relatively rare, it all comes back to the same input output. You need to have a ground truth, that same learning model. And if you, as the user, have a background on what you're using the system for, it's going to make your experience significantly better, because you're going to be able to know what you can trust, and you're going to be able to think twice and critically analyze stuff that doesn't seem to fit your mental model of whatever you're discussing.
Thank you. This is, as Robert said, the genie is out of the bottle. And so we can either stick our head in the sands because we're afraid, or because we don't trust, or whatever the negative motivations are, or we can figure out ways to use it because everybody is using it. And I think it's up to medical educators to show their group how to use it wisely, just as it is for classroom teachers to show their students how to use it wisely, that the human element is still
And something that I shared in the presentation is I really would encourage everyone to just use this technology. It doesn't need to be for work. It doesn't need to be professional. Use it at some part of your life and just explore it a little bit. Get a feel for it. It can be something as low stakes as just offering you a dinner recommendation, or making an itinerary if you're going to do a little day trip somewhere. It does not need to be, right into, okay, I'm using it to write practice questions, or I'm using it to critically think about different ways we can fix the hospital system. It can be something really small, but getting that foundational knowledge of, okay, this is how I use the system, this is kind of what its outputs are, this is how I interact with it, is really critical, because it's the same underlying system for all of it. It's just the content is changing.
One final question, if I can. ChatGPT is now, the data that it used is now 2 years old. Now that poses a potential challenge in a lot of different areas. As Robert mentioned earlier, the pace at which the world's knowledge, right, is doubling, it's down to hours now, by the way, not even days. So until these large language models catch up with the live internet, that's a potential problem, isn't it, in the medical field, outdated information?
Absolutely. And if you had said that yesterday, you would be accurate. Actually, this morning, ChatGPT was updated to April 2023, I believe, in terms of its knowledge cutoff. So they got you there.
That's good. That's good, though.
It does raise an area of opportunity for these systems that drives at this inter-observer bias and the spectrum bias specifically of the specific population. I really see these systems long term, and long term might mean in a year, it might mean in 10 years, but they're going to be self learning based on real-time information. I have zero doubt that we're going to continue this model of, okay, we train it all at once and we send it out. It's not the way that the systems are really being pushed to be used. They're being pushed to have that real-time beat, to have real-time and maybe medical, like epidemiological guideline-based knowledge. And I really think that we're gonna eventually have something that is, if not real-time, with at least a weekly or even daily update to these models. Because once you do the major training, it's not incredibly challenging to have refinements to the models. And I do think that long term, they're going to have an almost real-time update in terms of how the models are deployed.
Is there potential privacy? Yeah, sorry. Go ahead, please.
So I was just going to say, so I'm not a physician. I'm a pediatric nurse. I've been a nurse for more than 25 years now. Grew up in a time when we didn't have an EHR and it was all paper charting. And we had, you know, $1 million monitors that didn't interpret anything, but they had some basic knowledge, right? For VTAC or VFib. And what was funny to me is, you know, growing up in that, right? You can see how much it's changed. And now everything has analytics running on the back end. So where are those analytics going, right? Is this something that could feed into like ChatGPT and the AI models? Because I say that because I've had some background with, like, I was asked to come to American Heart to do some quality discussions because I don't know if you know, American Heart Association is really geared for adults, not necessarily peds. Most of your EHRs are geared for adult care, not pediatric care. So there's a whole lot that changes in the pediatric world. And I feel like we're advancing so quickly in the adult side, but we're always like catching up on the pediatric side. I feel like coming from Arkansas to Buffalo 3 years ago, right before the pandemic, was really insane. And then I'm used to rural, right? Because I have one freestanding children's hospital in an entire state. And we were, you know, pretty advanced for everything we were doing. I come up here thinking, oh, New York is really progressive. I feel like I went back in time 15 years in my practice. And it was shocking to me. And I'm like, how is it so different state to state, right? And we're talking about education, and I'm thinking, what is Harvard teaching for AI? What is UB teaching for AI? And then you look at Epic, and you look at Cerner, and you look at Meditech, and all the different EHRs, and how different they all are, and who can afford what, right? Because everything is so expensive now. And I realize all of this is free, but for how long, right? Like when do we start seeing it in the EHRs, right? We already see equipment now where, you know, the monitors are running full time and they're interpreting and analyzing and giving feedback, and it's, you know, so advanced, it's actually saving lives. Whereas when I first started, it wasn't, right? And so, like, it's, how do you keep everyone up to date with everything going? I mean, it's so much so fast. And like you're saying, like, we're increasing our knowledge hours now, like just thinking of the generations growing up in healthcare. I feel like sometimes I feel like a dinosaur, and I'm not quite a dinosaur yet, but I'm looking at you and I'm thinking, wow, this is going to be exciting for your generation. Very different for where I grew up in healthcare. I don't know. I don't know that there was a question in there, but I think my biggest concern is like how they monetize it, right? For capital or capitalism. And then the other thing is, what do you do when the servers are down? You don't have access to it and people are dependent on it. What do you do when those servers aren't working? And so it's just all interesting to me to watch this build.
Yeah, Sharon, thank you for sharing your experience. And I did get a couple questions out of that, so I'll try to answer those. The first one was looking at the pediatric population and technology changes. And I think that this is the same conversation with the minority populations that we were talking about earlier and the spectrum bias that you can have
Yeah.
there. If there's not a lot of research or data on it, the system is going to struggle the same way that humans do. And I think that the only real way to fix that is to have that data, to seek it out, to incorporate it. In terms of the monitors and how those can be integrated into this, that's on the specific health system, and the health data concerns around that are real. That's something that is you're really going to be working with your partners in the technology industry to make sure that you have robust security, privacy, that you have compliance, not just with HIPAA, but with the entire data pipeline. And that's part of the reason that when you look at the healthcare side of these applications, I can't say that I know the specific numbers, but I do know that it's quite expensive to incorporate the AI technology in healthcare. And part of the reason for that is you have the underlying technology, and then you also have a lot of extra work that has to go into EMR incorporation, into protecting that data structure and privacy. To your question about what do you do when the system goes down, I think that really is a great answer to the question, well, what do you need the doctor for? Well, you need to know your stuff. You as a physician, and I understand this goes outside of that, but any area where you're a professional, you need to be knowledgeable in your area. You cannot just be relying on an AI system to do your job for you, because when the rubber meets the road, you need to be able to act and to perform at that level. This is really a tool, and I like the Microsoft branding of the Copilot. I think that makes a lot of sense. I mean, this is a tool that you use. It is not a replacement. And in terms of your question about, the monetization and the specific, the capitalist side of things, there are ways that you can have these models, because the transformer architecture, the deep learning, that's not something that just ChatGPT or just Microsoft or just Meta has. It's something that you can feasibly train. It's expensive. And I know, like at UB, we have an AI division or department, and they can train models. I mean, it's not that this technology is somehow only able to be done by these big companies. It's just that it's really expensive in terms of the computers you need to train it and the time that those computers need to run. It's a challenging thing to just go out and do. And you also really need to consider that data set. Again, the inputs and the outputs. It is so expensive and to get good outputs and to get, the feedback into the system. And I'll finish up by saying that, you're using these AI models all of the time, even in your current life. If you have an iPhone, you might, Google does this as well. You might notice in your Photos app, your family and your friends, their faces all show up. And when you text someone, you have those auto recommendations. Those are now, if you're using the latest software, those are all transformer-based models, all of them. So every time you take a picture, you're running a massive AI model in the background. Every time you send a text, it's running an AI model to try to, improve the autocorrect. And so this technology is not only exclusive to these really big companies that you have to license out. It's incredibly challenging to do it at scale with the high baseline that we have for medical quality without having that big data set from the big companies. Did that answer your question?
Yeah.
Okay. I mean, I don't know if there really
It's just-
is an answer per se, but I hope that provided some context.
Could I also just jump in here, Sharon? I certainly understand your concerns, and let me ask you, because I think I know the answer, but when you're working as a nurse, how much time are you spending charting versus actual face-to-face time with the patient?
So when EHR first came out, we considered it our second, third, fourth patient because we had to spend so much time clicking through, and that was Meditech. And we had to, for our hospital, we had to really customize Meditech to work for us, to make it more efficient, right? Because anytime you have workflow issues, who's suffering? It's your patients. It's always going to be them. And so I would say once we transition to Epic, which I'm going to tell you, I'm a huge fan of Epic. I hate Cerner and everything else. Yes, huge fan. It was a little bit of a struggle, but everyone, like my whole hospital erupted in celebration when they told us that we were going to Epic, because we were spending so much of our time charting. And once we had Epic, I think it decreased, I would say almost by 50%, because it was so much easier to navigate the chart. Everything was all in one area. And it does take time and you get more efficient as you go. But I still tell you, like, I am one of those people. The problem with the computer for me was I'm one of those people that I like to see my entire flow sheet for the ICU, right? Like everything. I could see everything all at once just on my flow sheet. In Epic, our big problem was how do we make this more efficient so we could see the trending flow sheet? And so that was something that I helped build in our hospital, because our ICUs felt like we couldn't see the trends when everything was so segmented. It was great when we did it.
So to that point, I see, and I've looked at charts, and I marvel at all the stuff that nurses have to document. It's mind blowing, and I think it's causing a lot of burnout in nurses.
Oh, 100%.
I foresee AI taking over a lot of that charting. I think we can figure out how to get AI to do a lot of that charting and trending. And I'll take it even a step further. AI will help you predict what patient may be getting into trouble without you having to constantly go over and look at the trends when you're taking care of, 4 or 5 patients. It is got eyes on those patients for you. It's as John said, it's a co-pilot. So while you're looking at Mary over here, it's looking at John in bed 10.
Mm-hmm.
And it can, and I think it can potentially pinpoint problems far sooner than we may be able to in certain circumstances. So
for sure.
I think, and when you talk about cost, the cost of losing a nurse because of burnout, and then
Training.
recruiting a nurse, the cost of recruiting a nurse, a cost of training that nurse, or the cost of bringing in, someone from the outside to come in to fill in the gaps. That's really expensive. Those expenses go away. So yeah.
Well, and you're already seeing, I don't know if you guys have heard this, but you're already seeing like a virtual RN program coming into the hospital. So they're doing this, I want to say it was Northwell and another hospital downstate that's doing it. But there was 2 different models that they were teaching, and one was hardwired, one was like remote, like you could wheel it in. And so I don't know if you're familiar with like workstations on wheels, but like they have the computer and the cameras and all that. So they would wheel in the virtual RN, right? And the virtual RN would start the education, start doing, like they can do the med reconciliation, the medication history, start taking in information. And I thought that was super interesting because as you know, we're so much leaner than we were pre-COVID as far as like healthcare goes for physicians and nurses. And I think this is a great way to kind of answer that call and have an extra set of eyes on patients, because in an ICU, you're in and out, you see them more often. In a med surg area, it could be a couple hours depending on how the hospital is structured for rounding, right? And so I think that model was really interesting because it gives 2 different perspectives on how they're monitoring hourly and then how they're using it for education for quicker discharges and increasing throughput into the hospital. So, I mean, there's a lot of work happening. And so I keep thinking you're going to have a virtual and an AI RN coming in, and, this could be the next phase. It's going to happen.
That's your co-pilot.
Mm-hmm. For sure.
The entire medical industry, right, has huge labor shortages, because I work in an industry that also has huge labor shortages. And so it's going to be natural to look for. And one of the things I wondered about too is, to what extent is the insurance company, the insurance industry, because right now, I know in terms of the clinic I go to for my annual physical, they're really pushing the stay at home and do self checks and telemedicine and stuff. I want. Doesn't it seem natural that they're going to really be behind the move for the medical field to use AI more?
Yeah, I just worry more about like our rural areas where they don't have Wi-Fi and they don't have internet. And I think like so for my job, we go all around the 8 counties of Western New York to all the birthing hospitals. And when I go to a level 1 hospital, we're considered a level 4 at OSHI. And when I go to a level 1, I mean, they don't have 24-hour radiologists. They don't have 24-hour anesthesiologists. They can't read an x-ray at night, right? Like there's so many things that you could supplement with a little bit of AI in those areas. But I think for me, it's when you talk about disparities, it's not just our patients, it's the healthcare systems that can't afford to upgrade or can't afford the latest and greatest. And so they're still, boots on the ground trying to figure everything out. And it's interesting navigating that around the region right now and seeing where the real needs are.
Well, I did my first proof of concept project in 1998 with telemedicine with a medical suit. We then put together a multi-specialty, virtual multi-specialty group, and we did consultations and follow-ups and patients in the rural areas outside the Buffalo area. We had areas where they had Wi-Fi, and we had electronic devices, electronic stethoscopes, otoscopes, ophthalmoscopes, all that kind of stuff. So everything, you could do a full exam over the internet. So it made healthcare a bit more available in those areas. And I think you can marry telemedicine and AI. There's again, so many things.
So many.
That
it's exciting.
We have the technology. We just are a little slow in getting it out there. But as you know, healthcare in rural areas is becoming a major problem now. And I really, truly feel that telemedicine and AI can help fill that gap. We just have to be bold enough to get it out there. And we need people like John to be leading the
Yes.
charge.
Yes. Well, and we just got a grant from the state to really implement and increase our telehealth expansion for our rural hospitals. So I'm excited. Maybe I can pull you in. I just don't understand. Our physicians are just so nervous about it. And it's hard for me because it helps more than it hurts, right? And trying to get that buy-in is really hard.
That's that curve I was talking about. In 1998, when I talked to physicians about AI, they were ready to put the straitjacket on me, and it really didn't ever go away until COVID.
Right,
COVID
right.
was a game changer for telemedicine.
So yes,
One day it's nobody wants hands off, and then the next day, people are doing it because you had to. It was almost like you have to go down to your ashes sometimes before you change. But so yeah, I'd be happy to help in any way I can. It was a wonderful experience. Patients really appreciate it. First of all, it's difficult for them
to drive in, right?
It's a waste of time. And it used to be that we would go down there, which was also a waste of all that windshield time, driving down to these rural outpatient clinics and then driving back. It was too much windshield time. So that's where telemedicine, and it's also time is zero, distance is zero. So you're always available, and you can get it organized so that you cover for each other.
Mhm.
So
Mhm.
it's, yeah. I,
It was
I,
a great
I hope we
presentation.
can get it going, Sharon, because it's really important.
Yes. Oh, we, as long as I'm here, we're going to keep pushing. So
Okay, and if
we'll
there's
we'll
anything
get
I
it
can
done.
do to help,
Oh, I will definitely, I'll reach out. We will probably need some help. It feels like a big daunting task, but we have 5 years to do it. So, and the money's there, which is nice. That's not always the case.
And remember, we are a creative species. Okay, so
Yes.
Roger and I
Yes.
die by creativity, and this
Yes.
too we shall solve with the help of AI, of course. But well, Sharon, thank you for staying to add to the discussion. And Robert, as always, Robert, you're always the first one to respond when the email goes out announcing or reminding everybody. Thank you very much. It's always good to know somebody out there is paying attention to it. And John, we can't thank you enough as well. Good luck in your own studies. And boy, have you chosen two fields for your own passion that you are buying lifetime security as far as I'm concerned, because AI, medicine, goodness.
Dave, you might be interested in this, but there is now people are getting a dual whatever it is. They're getting MD and an AI.
Mhm.
Yeah.
So there's a MD AI program, so you can be boarded in both of those.
Yeah. A
And
lot
at
of
the Mayo
institutions
Clinic-
are
at the Mayo
adding.
Clinic, at the Mayo Clinic, they now have what's called the like chief of uh, they have the chief of AI,
Mhm.
just like they have a chief of medicine or the chief of
Informatics. Yeah.
informatics. Yeah. Now it's the chief of AI.
Is he an avatar or a real person?
That's a good question.
That's the next question.
Actually, I was going to ask John, who put that that your presentation together? Was it you or was it AI?
Oh, no, that was 100% me.
Yeah, I think I was just
Yeah.
anyway. Yeah.
Yeah, a lot of institutions are adding AI requirements. They're adding AI certifications to. I've seen a lot of in engineering, for instance, like your field, science, precision, right, dominated. So that's another field that's really looking at how to train the engineers in engineering schools, right, on how to use it. All right. Well, thank you again, John.
Yeah, I was just going to say, John, has Dr. Snyder connected you at all with the AI team here at Kaleida?
I don't believe so.
Well, I know that we have one because I've been in touch with a few people that they just started, and I think they're using Google. So, ask him about it. He could probably plug you in if there's a project or a study you want to look at.
Thank you for the
Yeah, you're welcome.
And John, if you would kindly send me a copy of your slides, I make those available along with the recordings. I have a feeling that we're going to have quite a few people watch the recording and want to take advantage of. I get a lot of responses to the email invitations. I can't be there in person because I'm on call or whatever, but I want to watch the recording. So thank
I'll
you.
send them off when we get off the call.
Okay. All right. Thank you all. Have a great rest.
Thank you.
Is it Thursday? Yeah. All right. Bye.
Thank you.
Bye.